Thank you very much. I'm a fourth year resident and I have a interesting case, an unusual case of encephalopathy. Can you all hear me okay, Rich? Is my
Yep.
volume okay? Great, okay.
Yep.
So we'll try to be brief about this because this is a kind of a complex story, but generally this patient is a 59-year-old gentleman who was admitted for an inpatient treatment of periorbital edema and preseptal cellulitis that had actually failed outpatient antibiotics. So he was brought in to get antibiotics, and his hospital course was complicated by encephalopathy as well as new onset focal seizures with secondary generalization. Early on in the hospitalization, there was an MRI brain that was completed, and that was notable for some juxtacortical ring-enhancing lesions, numerous ones that were involving the bilateral hemispheres as well as the pons with some surrounding edema. Now, fast forward, so kind of going back, when he initially presented, he was noted his exam to be only oriented to himself. However, he had no focal neurological findings that were seen by the patient's primary team. On the 10th, however, there was a stroke code that was called for some rhythmic left lower extremity shaking that then generalized to the whole body and lasted several minutes, and it was abated after he got a milligram of lorazepam. Following the seizure, he was notably obtunded with some right gaze deviation. Now, imaging was completed, and so this is kind of a compare and contrast, but the initial MRI on the 3rd showed numerous kind of juxtacortical ring-enhancing lesions involving the bilateral hemispheres and the pons with some surrounding edema. You can see those ring-enhancing lesions over on the top right. That's your T1 with contrast. And then there was also a CT head that was obtained following the stroke code, and that was notable for some diffuse cerebral edema, but no herniation was seen, and looked to be worse than the prior MRI. And there was also a noted new right parietal IPH. Now, there was no LVO seen on CTA, so that was reassuring that there was no stroke, but the repeat MRI did show that there was some worsening edema, and you can kind of see this flare imaging here on the right lower corner here, and this is another view of some of those ring-enhancing lesions. Now, some notable labs, lumbar puncture, meningitis panels negative, CSF showed elevated protein and normal glucose and mild lipocytic predominant pleocytosis, but the LP flow cytometry and cytology were negative for malignancy, and a pretty thorough infectious workup was done as well, and those were also negative for any of your typical infectious agents. So a biopsy was completed, and neurosurgery was involved, and they biopsied one of the brain lesions. And pathology was actually consistent with granulomatous amoebiasis. So this is a very rare, rare infection. On average, there's reportedly 3.7 cases reported annually worldwide. The basic 3 types of organisms that are involved are your Naegleria fowleri, your Acanthamoeba species, and Balamuthia mandrillaris. And generally, we kind of have to break down amoebic encephalitis into 2 different types of infections. There's the there's the granulomatous amoebic encephalitis, which is a GAE, so kind of referred to as GA from now on. And there's also primary amoebic meningoencephalitis, and that's PAM or PAM. So I think that that's an important distinction to make, because when you kind of break them apart, primary amoebic meningoencephalitis is usually caused by the Naegleria fowleri bug. And that is a thermophilic free-living amoeba, which we typically find in untreated fresh water. And it is the way it enters the body is different in that it enters through the olfactory mucosa. It crosses the cribriform plate and kind of seeds the brain from that point. Now, this usually presents as a pretty similar presentation to bacterial meningitis. And that is kind of in distinction against GAE, which is caused by Acanthamoeba species and Balamuthia, which typically is found in soil and brackish water and sewage, as well as humidifiers. This amoeba tends to enter the body through the eye, nasal passages, respiratory tract, or also ulcerated skin. And the difference here is Whereas PAM will tend to enter through the cribriform plate into the brain, GAE organisms tend to spread hematogenously. And that is how they enter the CNS. And when they do enter the CNS, they start to stimulate abscess formation and focal granuloma formation. So they have a different general presentation. They're more often than not subacute to chronic. Symptoms are usually weeks to months of progressive headaches, low-grade fevers, visual disturbances, behavioral abnormalities, and focal neurologic deficits, as opposed to PAM, where you get more of a acute presentation. It's generally within 9 days of the actual insult, where the water gets into the nose and that actually seeds the infection. That takes a much shorter time for PAM to start forming that, that meningitis picture. GAE generally leads to increased intracranial pressure, seizures, coma, and eventually death, whereas PAM is more of a bacterial meningitis kind of picture, and it's usually within days. Treatment. So unfortunately, due to the rarity of the disease, diagnoses tend to be made on autopsy, and there's really a lack of clinical trials on the effective treatments that are good for these infections. Generally, the CDC does recommend a course of pentamidine, sulfadiazine, flucytosine, and either fluconazole or itraconazole for GAE. Now, there actually have been 2 pediatric cases of chronic acanthamoeba meningitis, and they were successfully treated with a combo of some trimethoprim, sulfamethoxazole, as well as some rifampin and ketoconazole. Now, with PAM, this is better treated with amphotericin B, both IV and intrathecal, and it's also given in a combination with rifampin, fluconazole, miltefosine, and azithromycin in combination. Now, there's also been some possible studies done with mouse models that have shown that posaconazole may also be effective as well. And I think looking back on this patient's case, this is obviously more of a GAE kind of picture, and he has been treated with the combination of medications, but unfortunately the prognosis for this is almost universally fatal, and it is pretty grim overall. As for the patient, he remains able to open his eyes to voice, nonverbal though, and not following commands, will sometimes nod. And this is an update I just recently got. And he's got a grasp reflex on the right upper extremity, but otherwise he's not following any commands in any of the extremities, and no real significant improvement since starting antibiotics. So pretty unfortunate case, but it's I think a very interesting one. Thank you.
Thank you, Puya, for that interesting yet not quite uplifting presentation. But both our grand round speakers knew what the diagnosis was before you even mentioned it. That's a first. That is a first. Thank you, Puya. All right, I'm going to turn it over to Andrew now, who's going to introduce our speakers.
Thank you, Rich. Good morning, everybody. Welcome to our second of the Diversity Inclusion Grand Rounds lecture series. Actually, number 2 and number 3 this year are going to follow a theme which we haven't done in the past. And that theme is the role of race in medicine. And today we're talking about the use of race in medical education. And next time we're going to talk about the use of race in clinical practice, specifically neuropsychology and how race norming affects neuropsychological testing. So we've got a bit of a theme. So I want to introduce our 2 speakers today, and I really appreciate them coming to talk to us. First, we have Dr. Andrea Deyrup, who is a Duke Professor of Pathology, and she received her undergraduate degree from Princeton University in the Department of Ecology and Evolutionary Biology, and then went to University of Chicago for her PhD, MD, and residency. And she trained in soft tissue pathology at Emory, followed by a career here at Duke since 2015 in medical education. She serves as the Duke Pathology Department course director for first-year medical students, and has also served on the Undergraduate Medical Education Council for the Association of Pathology Chairs. She participated in the Duke Teaching for Equity Fellows Program, and when I met her, that was through the Duke School of Medicine Health Professions Anti-Racism Task Force, which we worked on together. And she's one of the co-editors of the new Robbins Pathology textbook. And so Any med student, resident, and attending out there knows Robbins pathology, and also the upcoming 11th edition of Robbins and Kumar Basic Pathology. And she's very actively committed to the anti-racism efforts throughout Duke, and improving discussions of health disparities in medical education. Our other speaker today is Dr. Joseph Graves Jr., and he's a professor of biological sciences at North Carolina Agricultural and Technical State University. Dr. Graves received his PhD in environmental, evolutionary, and systematic biology from Wayne State. His research into evolutionary genomics of adaptation shapes our understanding of biological aging and bacterial responses to nanomaterials. His multiple books on the biology of race, including The Emperor's New Clothes, Biological Theories of Race at the Millennium, The Race Myth, How to Pretend Race Exists in America, and Race and Racism, Answers to Questions, which...
Will, can you mute that, please?
Yes, I'm sorry. I'm
Sorry, Andrew, go right ahead.
Okay, got it. So he leads a program addressing underrepresentation of minorities in science and aids underserved youth in Greensboro through a YMCA chess program. And he's also served on the Racial Reconciliation and Justice Commission and the COVID Vaccination Task Force of the Episcopal Diocese of North Carolina. And he serves as the science advisor to the Chicago and New Brunswick Theological Seminaries through the AAS Dialogues of Science, Ethics, and Religion program. And so I appreciate both of them speaking today, and I will turn it over to the two of them.
All right. Let's see. Thank you very much. We have a tight program, so we're going to leap right into it. First of all, I'd like to thank you for inviting us here. We're very delighted to be here, in part because we know how committed neurology has been to DEI work, transparency, accountability. So we're very grateful for the light you are shining here at Duke. I'd like to begin with a disclosure, which is that I'm a co-editor and author of 2 of the Robbins pathology textbooks, and Dr. Graves is a paid consultant for the upcoming edition of Robbins and Kumar Basic Pathology. We'll be focusing primarily on Robbins Basic Pathology in this talk. So our objectives are to discuss the impact of systemic racism in medical school curricula, compare and contrast biological and socially defined race, evaluate disparities in the pathophysiology of disease, and to describe an approach to addressing health disparities in medical education. So the first question is, how does race show up in the curriculum? So I'm a pathologist, and Robbins Pathology is a textbook that we use to teach at Duke. So I did a search through the electronic text using terms like African, Asian, Caucasian, and came up with more than 45 diseases for which a disparity was listed either in incidence or prognosis based on socially defined race. Let's just take a moment to see how these associations are made. So here are 4 quotations from the 10th edition, noting African Americans and cardiac amyloidosis, carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and whites with factor V Leiden mutations. And let's just begin by just setting aside the outdated and inappropriate terminology, because that's easy enough to fix. And let's just focus for a moment on the fact that when these sentences were written, they were written with the best of intentions, with the idea that these epidemiologic data would help future physicians to come up with a broad and accurate differential diagnosis, to order appropriate laboratory tests, and to design optimal treatment for their patients. So these sentences were written with the best of intentions. But as we all know, it's not enough to simply have good intentions. We have to ask, are we causing harm? So are we causing harm? And I would say at this point, yes, we are. And there are 3 different realms in which I think we are doing this. The first I call buzzword bingo. So for medical students, we take very motivated, very bright individuals who are great at doing multiple choice questions, and we teach them simple word associations like white, cystic fibrosis, black, sickle cell disease. And we reinforce this through our exams, through licensing exams, through test prep material, and really hit this home. So Here's just an example from 2015, a website called crashingresident.com, in which the author was making recommendations for medical students on how to do very well on step 1. This is just one section where he recommends that they be as racist as possible. Now, for those of us who have taken our boards, who are residents, fellows, and attendings, I think we will recognize these associations as things that we ourselves learned as we prepared for the boards. These were buzzwords. As you skim down the vignette, if you saw the patient was listed as African-American and had a variety of symptoms, you might think, oh, sarcoidosis. Oh, it's a Black woman, it's gotta be sarcoidosis. So these associations come through. Now, here's a more recent paper from 2017 in which the authors looked at a very widely used test prep resource called QWorld. I think this is used by pretty much all medical students preparing to take step 1. And the authors looked at the entire 2,000 plus question bank using once more search terms based on race and ethnicity. And they categorized them as to whether or not the use of race or ethnicity was simply descriptive, like saying someone was a CEO or was a lawyer, or whether it was central, so that knowing that person's race or ethnicity was key to getting to the correct diagnosis, to the correct answer, or to understanding why that answer was correct. Now, what you can see here is that white Caucasians were about 86% of the individuals in the vignette. This is important to recognize that actually this population is about 62% of what we see in the United States. So this is some more race norming, that everything is focused on white Caucasian. You'll also see that about 93% of the time, if you were white or Caucasian, it was just descriptive. It had no impact on whether or not what the diagnosis was or the treatment. And only about 7% of the time was race important. And this is probably going to be something like cystic fibrosis. By comparison, if a Native American shows up in that vignette, they are there because they have gallstones, diabetes, or severe combined immunodeficiency. They're not there because they were in a motor vehicle accident and have an epidural hematoma, or because they brushed up against poison ivy. So this is once more emphasizing this. Now, you may say, well, these are just, the preclinical years. And surely as our students go through the wards and become residents and attendings, they learn the full spectrum of disease and health based on population. I would counter that by saying that there are things I learned 20 years ago at the University of Chicago that I did not learn were false until I began really looking at race in medicine. Now, the next question we have is it possible we're causing patient harm? And I would again say, yes, this is possible. So say a young Navajo woman presents to an acute care clinic. She's got right upper quadrant pain, and the attending thinks, oh, Native American, must be gallstones, and overlooks an ectopic pregnancy or an acute appendicitis, either of which can be fatal. Now, you may say, again, well, we have algorithms, we have checks and balances. This isn't going to happen these days. Well, I would counter that again with an accounting here from an article, The Misuse of Race in Medical Diagnosis, about a girl who wasn't diagnosed with cystic fibrosis until she was 8 years old, despite presenting multiple times with suspicious symptoms. And in fact, she was only diagnosed when the radiologist could not see the color of her skin and was just looking at her chest film and said, who's the kid with cystic fibrosis? There was a recent account in another journal about a man who's African-American who wasn't diagnosed until he was 54 years old. So this is clearly an ongoing problem. Now, finally, as long as we're looking at this, I think we have to say, is there a way that we might be causing societal harm? Are we perhaps taking one population and elevating it and another population and lowering it, perhaps saying they have faulty genes, risky behaviors, non-compliance? Is there a way that we are separating populations and creating a hierarchy? So to look at this, I will show you by redlining the diseases in Robbins' 10th edition, which are associated with a worse prognosis or higher incidence in African Americans. And for comparison, here are the ones that have a higher incidence or worse prognosis in European Americans. So I think we are setting up a hierarchy here. Now, to further discuss what we're talking about when we discuss race, I'm going to turn the talk over to Dr. Graves.
Thank you, Dr. Deyrup. So when we ask this question, what is race? In modern biology, races are defined by two criteria: the amount of genetic variation within and between groups, and whether a group can be considered a phylogenetically unique lineage within a species. Now, it's long been known that in humans, there's more variability within so-called races than between them. We do have geographically based genetic and physical differences. So let me be clear on that, because folks often confuse the existence of geographically based genetic variation with the presence of race. They are not the same things. And any two human beings drawn from any two places in the world are likely to share 99.9% of their genome. Next slide, please. So biological race does not exist in modern humans. Instead, most people are referring to socially constructed or socially defined race, which arbitrarily utilizes aspects of morphology, geography, culture, language, and religion, but only does so in the service of a social dominance hierarchy. And thus the title of my new book with Alan Goodman is Racism, Not Race, in which we make the point that it was racism that created socially defined races, not the other way around. Now, this is an idea that's gaining more traction in biomedical research. For example, Merrill's Introduction to Epidemiology in the 7th edition states, race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Next, please. Racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. So note that Merrill is not saying that these conditions result primarily from genetic differences between these groups. Next. Now, if we look at how the US Census Bureau has treated race, and by the way, the census actually has a disclaimer that says that these categories are not biological or anthropological or scientific in any way. I just wanted to let you know that up front. So white, person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But then you could ask the question, how much? Because African Americans have ancestry from that region of the world as well. And again, Black or African American, a person having origins in any of the Black racial groups of Africa. Okay, again, how much? And this is important to recognize because sub-Saharan Africans have more genetic variability than all of the rest of the world combined. So another way of saying that is if you were to choose two Africans at random and then compare them to an African and a European at random, the two Africans are likely more genetically different from each other than the African and the European are. Now, American Indian or Alaska Native, a person having origins of any of the original peoples of North and South America, and who maintains tribal affiliation or community attachment. So in other words, someone who leaves the reservation is no longer part of the tribal affiliation, is by the census no longer American Indian. Now, I find this term even more useless, Asian, a person having origins in any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent. So really, I mean, we're talking about a huge geographical area, Cambodia, China, India, Japan, the Philippine Islands, Vietnam. Okay, again, the utility of this as a characteristic, as a classification, I mean, for biological sciences, biomedical research is highly suspect. Finally, Native Hawaiian or Pacific Islander, person having origins of any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islands. Dr. Deyrup.
All right, so with that brief discussion of race, let's look at the world and see where these racial characteristics may come in. So I hope all of you remember from medical school about the hemoglobinopathies and how they arose in response to evolutionary pressure from malaria. So this is a map looking at a variety of them, including thalassemia, hemoglobin S, and hemoglobin C. Now, as you can see here, this is the area that's encompassed by Asia, all right? And we frequently see in the text that Asians have a higher incidence of thalassemia. Well, yes, some Asians do, but there are a whole bunch of Asians who don't, all right? Because what is determining your risk of these hemoglobinopathies is not the country, the continent. It has to do with whether or not your ancestors experienced evolutionary pressure from malaria. So if we look here at Africa, we commonly will refer to sickle cell disease as the African-American disease in this country, but you can see there are large areas of Africa that don't have sickle cell, and there are areas of Southern Europe, the Middle East, and India, which do have hemoglobin S. So I'll describe in a moment why it is we consider this to be the African-American disease here. Now, just to highlight for you the fact that it's not the country or the continent, here's this area in the middle of Africa or Northern Africa where there are no hemoglobinopathies. And the reason for this is the Sahara Desert and there are no mosquitoes. With no mosquitoes, you have no malaria and you have no hemoglobinopathies. So let's take a closer look here at Africa. So we can see here we have the band of hemoglobin S and hemoglobin C. And if we were to compare this with a map that shows where enslaved peoples came from in the history of this country, you could see that even knowing nothing about modern United States, you would expect us to have a reasonable amount of hemoglobin S and probably some hemoglobin C. And you would be correct. So this comes from a single study from Howard University and their sickle cell screening clinic. You can see most people have hemoglobin A and have healthy red cells, but we have a significant amount of sickle cell trait due to hemoglobin S as well as hemoglobin C. So the reason that we consider sickle cell disease to be an African-American disease is because of our history of chattel slavery. If slaves had come from India or the Middle East or Southern Europe, we might very well consider sickle cell disease to be the Indian American disease or the Middle Eastern American disease. So it comes purely down to this. And we'll see more of how the history of slavery affects the ancestry of individuals in a moment. So you may be thinking by looking at this, well, I'm beginning to come up with it. I can no longer say it's the African-American disease, but I can say it has to do with geographic ancestry. But you have to be very careful because you can't just look at someone and know their geographic ancestry. Just because someone has dark skin does not mean that that person is a descendant of enslaved peoples. So we have a rising share of the US Black population is foreign born. And something that Dr. Graves is going to talk about is population admixture. So even if someone has dark skin and appears to you to be of African descent, they can have a significant contribution of European ancestry, which can, here we say the average or the mean is about 16%. It can be as high as 50%, as Dr. Graves will discuss.
My apologies. Recent paper from Ancestry from 23andMe utilized Illumina V1, V2 panel and 25,000 custom SNPs to look at the ancestry of African Americans. And what you see is that the ancestry, European ancestry in African Americans is considerable. The mean across the country is around 16% European ancestry, but that can differ dramatically depending upon the region of the country. For example, in West Virginia, it's upwards to 30% European ancestry. And in Washington State, there are similar values. Next slide. Now, when we consider people in the Latino category, the admixture is more complicated because it's a tri-admixture between European, African, and Indian ancestry. And this can range between 65 to 85% European ancestry. And the next slide shows how this is even more complicated when we look at the Caribbean and Latin America. So for example, on the island of Puerto Rico, and there are actually more Puerto Ricans in the continental United States now than there are on the island, their ancestry tends to be about 72% European, 16% Amerindian, but 12% African. But Mexican Americans, the largest Latino group in the United States, their ancestry is 51% Amerindian and around 46% European, but only 3% African ancestry. Now, if we go to a country like Peru, it's 80% Amerindian ancestry with, again, virtually no African ancestry. And in Colombia, we're closer to, the Puerto Rican values, but that can differ dramatically depending upon which state or region of Colombia, as the next slide shows. So, for example, in the state of Medellin, the city of Medellin, the African ancestry of people in Medellin is closer to that we see in, the general, Latino characteristic, with most of their ancestry being European, and about a third of it being Amerindian. But when we go to the neighboring state of Choco, their African ancestry is similar to that of African Americans, but with a higher percentage of Amerindian ancestry. Now, the difference between Medellin and Choco, of course, is historical, because Choco was a site of enslaved plantation agriculture, and Medellin was not. Next slide.
So, as you can see, I think just from those figures, race is not a biologically useful construct, right? Even using a socially defined race isn't going to tell you anything really about that person's genetic ancestry. So why are there racial disparities in health and disease? So a lot of focus is on the intrinsic causes of disparities. There's a lot of money and a lot of research being done on this, looking at allele frequency and genome-wide association studies. And here are some of the genetic causes of disparities. So you can have a founder effect or a population bottleneck, for example, for the Ashkenazi Jewish population following the Holocaust, or the genocide of the American Indians in the 19th century in this country. But this is affecting populations, not races. There's also the process of endogamy, which means marriage within, or to be more specific, breeding within a particular group. So that can be based on religion, caste, or geography, but once more, not based on socially defined race. And then finally, we have a selective advantage, as we discussed for sickle cell, which is based on geography. But despite the focus on intrinsic causes of disparities, the real mover of disparities, particularly in this country, is going to be extrinsic causes. So, and many of these are linked. So poverty is going to be linked to access to care and living conditions, exposure to particulate toxins, to Superfund sites, to stress, to food access, to neighborhood. And many of these, in fact, probably, I would say all of these are also affected by individual, institutional, and systemic racism. Now, I know as a department, you have discussed this a great deal, but I always like to define terms. So I just would like to take a moment to go through this image from dismantlingracism.org, which talks about personal, institutional, and cultural racism. So I think prior to the murder of George Floyd, many of us, myself included, particularly people of white privilege, thought of racism as being primarily personal. It was individual heinous acts perpetrated by overt racists, often in white robes, burning crosses. And what I and many others have come to realize since then is that racism is really the water we swim in. So institutional racism are the policies and practices of institutions like hospitals and universities that include and serve financially resourced white people. An example of this would be when fetal ketonuria testing was first begun, the first screening tests, they only looked at white children because of the belief it didn't happen in Black children, which of course is false. And then cultural or systemic racism are the beliefs, values, and norms of a society, which similarly uplift and validate and protect white people at the expense of people in communities of color. An example of this is our society does not believe in universal health care. And you know this has a tremendous impact on health disparities. And then, of course, there's redlining, on which the US government made it more challenging for African Americans to get mortgages at favorable rates, and therefore had an impact on generational wealth. So let's look at these extrinsic factors in the context of disease. So here is something from Up to Date based on the two studies below, looking at women who underwent hysterectomy. Now, as neurologists, it may be a while since you've thought about hysterectomies, but there's basically two large categories. There's the open hysterectomy with a large abdominal incision. And then there are the minimally invasive techniques, which can be laparoscopic or a vaginal hysterectomy. And what these studies found is that eligible women who were Black, Hispanic, or publicly insured were much less likely to receive these minimally invasive techniques compared to white women. So you have a population that probably doesn't have a lot of sick days because they're publicly insured. They may be in a profession in which, or a job where they have to lift objects, there's manual labor. And with an open hysterectomy, there's significant morbidity, much longer recovery time. And I would say that the factors involved in this would be systemic racism because of the link to public insurance, institutional racism because the hospitals that served these individuals had fewer surgeons who were expert in minimally invasive techniques, and then poverty, education, access to care, health insurance. And then if we look at the statement from the 10th edition of Robbins' Basic Pathology regarding high blood pressure and its impact on African Americans, we would say that all of these factors come into play. There is no slavery gene, regardless of what you read in the popular media. So I'm going to quickly just take you through an example of what we're doing in Robbins. So after I found these different these disparities in Robbins, I spent about a year going through the literature, and I have a document called the disparities document, which I'm happy to share with anyone who wants it. I just would point out that the chapters were written by different groups or different authors in that edition, and there were no neurology or neuropathology focused disparities. Now, I know that there are disparities in neurology, but the author of that chapter did not focus on them, unlike authors in other chapters. So I can't give you a neurology specific example because that's not one that I've done a deep dive into. So I put this together, and I have a website, pathologycentral.org, in which I'm doing videos on this as well to try to spread the word on these falsehoods. But let's focus for a moment on cardiac amyloidosis. Coming back to that earlier sentence I showed you at the beginning of this talk with the transthyretin mutation and cardiac amyloidosis in African Americans. So just a refresher, transthyretin transports thyroxine and retinol in the blood and CSF. It's secreted as a tetramer, but it can dissociate into monomers, which can then misfold and aggregate with deposition in the heart, nerves, and other organs. In 1989, a pro-amyloidogenic mutation was identified in a 68-year-old African-American man. And since then, we found that about 3 to 4% of African-Americans have this allele, compared to about 0.4% of European Americans. It's an autosomal dominant variable penetrant allele. So just because you have it doesn't mean you're going to express the disease. And it tends to affect men over 60, which is important because it can mimic hypertensive cardiomyopathy, which is frequently seen in this population. Individuals with this mutation, with this disease, tend to die 2 to 6 years after diagnosis. Now, based on the allele frequency, it was thought there might be some sort of founder effect. And we're fortunate that the research has been done to look at the distribution of this allele in Africa. And you can see again that we have a high concentration here in Western Africa and then across Central Africa. And if we put the map of the origin of enslaved peoples here, you can see why we would have a high incidence of this allele in our country. And if this were all we had, it would be an interesting story, and that would be all we would do with it. But it turns out there is a treatment. So there's a drug that will bind to the thyroxine binding site, prevent dissociation. So it does not cure the disease, it does not roll it back, but it slows progression. Now, one problem with this is that this drug costs about $225,000 a year. And one of the reasons is it's not used very much. We're not identifying patients who need it. They don't have advocacy groups. There's no lobbying for it. So this is one of the challenges that we're facing. And brings us again to our question, is race in medicine data or distraction? All right. And I hope at this point in the talk, your antenna have gone up. You said, no, got to get rid of the word race. Is this focus on disparities in medicine data or distraction? And I would say, yes, it's data if we are using this information to identify populations that could benefit from a therapy. It's distraction if we say, 94% of Americans who have cystic fibrosis are of European descent. So I'm going to focus on that. And if I have someone who's not of European descent or who doesn't appear to be of European descent, because once more, we can't tell, as Dr. Graves has said about population admixture, if someone doesn't appear to be of European descent, we're not going to put that on our differential diagnosis. So what do we do? How do we fix this? How do we make it data and not distraction? So these are the three steps that we're employing. One is inclusivity. The next is thoughtful, mindful analysis, the material driven by data, and finally providing context. So for me, the first thing I do is I build a team. Dr. Kenny Raley here at Duke has been a tremendous ally in this work. Dr. Wigfall introduced me to Dr. Royal, and I'm grateful to these two in particular because they led me to Dr. Graves. As an evolutionary biologist, he brings a unique, valuable, and essential perspective to this work. So what we're working on is being scientifically correct, not politically correct. And he has extensive experience in this realm. As he mentioned, these are three of his books. I highly recommend Racism Not Race. It's an excellent reference for physicians. And then once you start this, continue to build your team. So bring in as many people as you can, because these people are all coming from different walks of life, looking at gender orientations, gender identity, sexual orientation, different racial and ethnic backgrounds, so that we can be as inclusive as possible. We need to bring in the medical students and the residents. These are people who are living this now. I am studying it and living some of it, but they are really immersed in it. So for example, for Robin's Basic Pathology, I put up a Google Doc and said, if you see anything problematic, let me know. And I know this can be challenging because medicine is a very hierarchical society. But once more, I know that your department, with transparency and honesty and vulnerability, is really working, and humility is working to contribute to this conversation. And then we have to take this to inclusive images. So at Duke, we don't include race or ethnicity in our vignettes for our medical students on the pathology website, but we do have clinical images, and it's quite clear that this is an individual of European descent with this basal cell carcinoma. So what we brought in last year was to show multiple images, and we are doing this in Robin's Basic Pathology 11th edition as well, because as you can see, it looks very different in pigmented skin. In fact, to me, this mimics a melanoma. So it's useful for our students to see this, and it is what is the right thing to do. So finally, I'm going to go through a little exercise, which is also in the disparities document, which is question everything. So whenever you see race mentioned, this is more common in this race, and that is more common in that race. This has a worse prognosis in this race. Ask why. So this is a sentence from Robin's Basic Pathology, and I reached out to the author of that chapter, and I said, I'd recommend we remove this. And his response was, well, this is what it says in Up to Date. So because of my disparities document, I had read Up to Date as well as reference 5, which is shown here, Robles and Berg. And one of the things, and I do a deep dive into the 5 to 16% in a video, and I'll give you the link to that in a moment. But I noticed in this article, they mentioned this fact that keloids are 15 times more common in dark-skinned individuals compared with whites. And this is a big number, and it was striking, in part because I saw it in 4 other journal articles. Now, Brissett was the one that seems to be the index of this. It was the first time I saw this quote. And this is the quote from Brissett saying, in a review of 175 cases of keloids from various races, the authors found keloids were 15 times more likely to occur in darker-skinned individuals. Being a bit OCD, I pulled that paper, which was from 1969. The study was done in Malaysia, which is why they're looking at Chinese, Indians, and Malaysians. And this is what it actually says from their data, that the relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. So the arrow is pointed in the wrong direction, and the number is wrong. So it's 2 to 3-fold, and it's the opposite. But this factoid has now, this falsehood has now been propagated through the literature. So after I presented all of this to my author, this is what we came up with. Keloid formation seems to be an individual predisposition. And that is true. But I would go a step further to say, why is this even relevant? Why did this even come in the first place? Because if you want to know if an individual is prone to keloids, you don't need to look at the color of that individual's skin. You can look at that person's actual skin, right? Have they had a cut, a piercing, multiple piercings, scrapes, any of that, a previous surgery? If they are prone to have a keloid, they will have a keloid. Now, for children, or just to be on the safe side, get the family history. So you will ask, do the brothers and sisters have keloids? Aunts, uncles, cousins, parents, grandparents. And that will tell you more about that individual's personal genetic ancestry than anything related to how they appear or how you judge by looking at them. So look at the patient, take a clear clinical history. That's really what we need to do as physicians. Now, as I mentioned, I made a video. I think it's pretty fabulous. It's 20 minutes long. And as neurologists, you may think I cannot possibly bear to spend 20 minutes looking at a video about keloids, but it's actually beyond that. It's about looking at systemic racism in the literature. And I sent this video to the authors of Up to Date. This is the actual section from Up to Date where you can see the 5 to 16% here. After several emails, this is now what it says in Up to Date. The link to socially defined race has now been removed. And there's still more work to do, but science has in fact prevailed. So finally, I'd just like to say it's really important as we write papers, as we do research, as we teach, to use appropriate terminology and provide context. So here's one sentence from the 10th edition of Robbins' Basic Pathology, referring to the factor V Leiden mutation in whites. Now, we know this is a mutation, so we really want to emphasize ancestry, not color, because we've avoided using color in the next edition, because if we're going to use whites, that means we have to use blacks, browns, yellows, and reds, and nobody wants to do that. So we're emphasizing European ancestry, but we don't want European ancestry to be a cue, like we're saying, when Deyrup says European ancestry, she really means white. We want to emphasize for our students a population admixture. So keep that door open. And this is particularly important in factor V Leiden because heterozygotes can be thrombophilic, not just homozygotes. Here's my list of references. I'm happy to send these to you. I'll send you the individual PDFs. And I'd like to finish with a cartoon from an amazing woman. She's a cardiology fellow at University of Chicago named Shirlene Obuobi. And her website is here. I recommend you check it out for her incredibly insightful cartoons, as well as her insightful and incisive comments about race in medicine. You can email myself and Dr. Graves, as well as follow both of us on Twitter. I have a website called pathologycentral.org, in which I am continuing to add videos on race and medicine. And then also, if you're interested in learning more about sort of diversity in medicine, Diversify and Path has an excellent series on that, and I was one of the people who was interviewed. All right, thank you very much. I know we're right up on our time, so we'll take any questions. I'm happy to stay for a little bit afterwards or to have follow-up conversations.
Thank you so much. That was terrific. And in fact, I was even getting chatted private messages of how great that was while you were talking. So really, really fantastic. Thank you for doing that. You know, there was an effort by students. You mentioned how you were inclusive of students in this process. Maybe you can talk, if you know, I'm not sure if you know the story of how we started talking about race in GFR and how Duke has changed its policy. Maybe you can give people, because GFR, yeah, we're neurologists, but we're obviously checking GFRs all the time. So maybe you can talk a little bit about that process and what went down.
I actually was not involved in the GFR project because the kidney has always frightened me, I'll be honest. But so if you are familiar with that, please feel free to share that. I mean, there's obviously a lot to talk about with GFR, and I've worked, I don't know if you're familiar with Jennifer Tsai, who's an emergency medicine resident at Yale, who's just amazing. TSAI, I recommend checking her out. But she and I have started a discussion along with Melissa Upton, who is the former president of the American Society of Clinical Pathology, about working at this on the national level. So we fixed it at Duke. They're working on fixing it at Yale. There are some issues because reference ranges are not meant to, they've never been meant to say, you know, this, I mean, what it basically does is it reflects what we see in the population. So if we were using BMI, a reference range for BMI, that's not supposed to say this is what's healthy. That's just what we see. This is falling within the range. So it's a little tricky from a philosophical point of view to simply say this is optimal, because looking at reference ranges, they vary all across the country. And so I think that the idea had never been to use them actually for necessary clinical guidance and cutoffs for therapy, but to say this is just where we tend to see it. Clinicians were expected to use clinical judgment, but then we got into this thing where if something is above or below a range, you know, it turns red or you get a phone call from the lab. And so it became a metric as opposed to a data point.
Yeah, and I don't know, because I wasn't part of the process either. I do know that it was a student-driven effort to remove race from GFR calculations. And now if you look, it actually has different language associated with it. And we're trying to prevent the disparity in things like kidney transplantation, where you don't get services because you're judged to have better functioning kidneys than you really do based on this arbitrary correction factor. So it was a student-driven effort, which I thought was pretty impressive. So there are a couple questions. There's one in the chat that I want to get to. It was about, this is from Dr. Liu, and he had asked about, okay, we've got this question about the Asian population, Dr. Graves, and he mentioned how it was a very broad category. He said, well, okay, let's talk about an alternative. Andy, if you're still on, you're welcome to ask the question yourself. But otherwise, Dr. Graves, what would you say is the better way of creating that group, I guess?
The question is, why do you need that quote group? You know, the best, simplest thing to do is they ask the individuals what their ancestry is. For example, my wife is Korean, and Koreans have different allele frequencies in a lot of medically important genes than Laotians do, right? So if you see people who look like they're from East Asia, and you assume that all of their underlying genomics are the same, that's a real mistake. So, I mean, again, I think the best thing to do with individuals is be as specific as possible with regard to their ancestry. In some cases, ancestry may be informative. In many cases, it's not informative at all.
I'd like to comment on that. There's a really fantastic paper that came out, I think 2018, looking just at Southeast Asia. Okay, so primarily India, but also some associated areas. And they did genetic analysis on, they identified linguistically separate populations. Now, the reason I mentioned caste is because there is a lot of endogamy in India because of caste. And they actually found, they looked at 260 populations, and I think they found that 81 of them had less genetic variation than you see in the Ashkenazi Jewish population or in the Finnish population, which are the hallmarks we use for saying there's a high risk of recessive diseases. And this is so well known in India that if someone comes and their last name is Reddy, then you expect them to have a higher risk for certain diseases. And then there's a particular population in which they have a susceptibility to anesthetics. And this is based, so these are 81 groups out of 260 that were looked at in one country, right? And so we can't even use the term Indian, right? We can't, now that, ethnicity is the new race, right? So people say, oh, race is a bad word. We'll use ethnicity. So we'll say, Indian ethnicity, but we can't even do that, which is why, and I think the question that Dr. Liu is asking is not so much about individual patients, but for research, right? Because you're not going to, I know we check off these boxes in when we do our EMER and stuff like that, but the question is, how do you categorize people by races? And my point is, and what Dr. Graves has said, well, is that even useful? So there is one instance in which we really need to, of course, keep this open, which is socially defined race has, as we discussed, a tremendous impact on health, not biological race. So if you want to look at vaccine, how many people are getting vaccines in different populations, delay in diagnosis in African Americans, the rate of transfusion reactions in certain groups. Yes, in that case, you want to think about socially defined race because that has to do with access to care. But as a biological category, if you're thinking about individual patients, that's going to get you into trouble. And if you're thinking about, and the solution is simple, examine the patient, get a good clinical history, good family history. If you're talking about research, I personally think that 99%, if not more, if not all of the research that's being done looking at, there's some populations which have certain differences, but I think 99% of the research is garbage. And I think the way that we looked at it, and I know that's a very incendiary comment. So, but
it's
I
really
think
not
that,
incendiary.
Okay.
It's not.
If it's
That's the truth.
even
It's
if
the truth.
true, but the truth can be incendiary, as we know. So anyway, that's my 2 cents.
So we've got a question from Dr. Sanders. Dr. Sanders, you still on?
Dr. Graves, I would like to hear your thoughts on the purpose and use of the census racial designations. These are self-identified, I assume, in the census, but why do we have those and what are they used for, potentially or especially politically?
And you said the word. They are political designations. I was actually a consultant on the last census. And the census has changed. Census categories have changed since the census began in the 1790s. And so as different populations began to be part of the United States, more and more groups were added to the census. And again, that disclaimer, these are not anthropological or scientific groups. I had a part in writing that disclaimer, but they're absolutely that. They are to measure things like discrimination based upon socially defined race and ethnicity. Now, one of the problems that they have in Europe, like for example in France, is because they don't collect data on socially defined race or ethnicity in their census. A lot of discrimination is unaddressed in that nation. And so we're capable of seeing, for example, using census data, that African American families are worth 1/10 European American families in mean wealth. If you weren't collecting that kind of census data, you wouldn't know that. We're able to determine that there are health disparities, okay, in terms of things, like infant mortality. If you weren't collecting that on the census data, you wouldn't know that. So they're not scientific categories, but they are useful sociologically.
And they are based on the individual's selection of their quote racial category.
And that's because in this society, people are racialized. In other words, I didn't get to choose my race. Okay, when I was born, my birth certificate says colored. I was born 1 year after Brown versus Board of Education. Emmett Till was lynched in the year I was born. My birth certificate says colored. I didn't get to choose that. When I went to school, I was defined as colored. I didn't get to choose that. Okay, I can tell you a funny story about the census. When I was a professor at Arizona State, census worker comes to my house and they have their little form. They look at me and they click Black African American. And then they asked me they were about to click Black African American for my wife. And I said, no, my wife isn't Black. She's Korean. And as soon as I said that, the census worker took 2 steps back from the door, but then marked Korean. And they asked me, how many children do I have? I said 2. They then proceeded to mark Black African American. I said, wait a minute. I just told you my wife is Korean. And they took another 2 steps back from the door because they simply didn't know what to do because there was no category. So, I don't think it's just that individuals identify themselves to the census. The census workers are also living in a racialized society, and they themselves play a big role in deciding which race to put people in when they're collecting this data.
What do you suppose
So
would have happened if you told them that you were Korean?
Well, I mean, I could have told them, that I have at least 5/16 of my ancestry from Europeans, right? And then I don't know what he would have done.
I do want to point out one of the challenges of this this classification. So as Dr. Graves mentioned, it's really important to be aware of disparities, health disparities, access to care, and in research studies, for example. So that's why the NIH now says you have to have a certain percentage of your study subjects have to be, whatever they have ratios, et cetera. That's because everyone was just doing their research on white men because, they were, the military, it was easy to get, they didn't have hormones that cycled, every month. And it's, there's mistrust of medicine and science, and rightly so in people of color, populations of color. So now we collect these data. Well, what happens is, and this is just a real tragedy, is that there's this proliferation of papers because people have done the work, they've got the data, and nothing is significant except race. Now, why is race significant? Well, because of all the extrinsic factors we just talked about for health disparities. And so I've seen, garbage papers on orthopedics where they say, oh, we looked at rotator cuff surgeries and found that, Blacks and Hispanics had, worse damage and didn't respond as well and had longer convalescence. And it's like, well, of course they did, right? But this is like in this race to publish, people are now further racializing medicine because I can get a publication out of this by emphasizing, oh, there are racial differences. And then there's that classic thing, about, well, further research needs to be done, and further research is never done. But the other thing that I think is really challenging is that I see these papers where they refer to, we examined socioeconomic status, right? So we took this into account. We looked at cultural determinants. And I'm like, okay, which ones did you look at? You looked at income, you looked at zip code, maybe education. There are so many, and that was what's shown in that final cartoon, that we aren't even thinking about or looking at. It was only recently we started looking and documenting the exposure of populations of color to particulate matter in the air, right? Association with Superfund sites, exposure to lead. There are all of these things that we're not, we can't say we've looked at even 10 different categories of socioeconomic status, and therefore we can say it's still race. There are things we don't understand. And I know Dr. Graves has more that he could say on that.
Yeah,
well.
I was going to say, because when they're saying race, they mean socially defined race. Because, for example, and data show that, for example, someone like me, I don't get paid the same amount as a professor of the same years of experience and expertise, who is of European descent. In fact, I made a joke about it last night. I tweeted out that, I know all these people who hold named and endowed chairs. And so I said, I'm going to claim the title of let me read it because it's actually pretty funny. Yeah, say I'm gonna, the title of the poor Black folks who can't afford to name a chair, professor of biological sciences. And so even though, I have, same years of experience, in fact, more publications than people I know with endowed chairs, I don't have an endowed chair. I make half what they make. So these things are real. Structural racism is real, and measuring socioeconomic status by income doesn't capture.
And to take that one step further, there's another excellent cartoon by Dr. Obobi, and I've looked at some research on this. I cover this in a cystic fibrosis video on my website, but looking at difference in funding for cystic fibrosis, which affects about 30,000 Americans, and for sickle cell disease, which affects about 100,000 Americans. And if you look at the amount of money per patient that we see for federal funding as well as foundation funding, Obviously, cystic fibrosis seen in European Americans just is blowing it away. They have much, much more funding. And part of the generational wealth issue and the chair that Dr. Graves referred to is that if I'm of African descent and I have a child with sickle cell and I want to donate money for research, I don't have nearly as much money as a Wall Street tycoon whose daughter has cystic fibrosis. And so that we see reflected in the foundation money. So it carries on in every aspect of health and disease in our society.
Yeah, another example of that is, if you calculate the endowment of the top 5 historically white institutions in America, that endowment tops $178 billion. If you calculate the endowment of the top 5 historically Black universities in America, it barely goes over $1 billion. There's over 100 times difference.
So I'm gonna say that there are a lot of questions left in the chat. We're not gonna have time for today, and I apologize to anyone whose question we didn't get. We could, I think, probably discuss this for another couple hours just this morning alone, and do it again next week, and still have more questions and more topics to discuss. But just given the time, I'm gonna say a big thank you. Really, really terrific presentation, and I appreciate both of you very much for sharing your thoughts with us. Dr. Deyrup, Dr. Graves, thank you so much.
Okay, thank you for having us.
Thank you. And Dr. Van Landingham, if you're still here, are you here? Had a question about why you hadn't, why no one knew about your oop, Joe's gone. Well, there you have it. Bye-bye, everybody.
I was gonna take that. I don't think he's here anymore. I was gonna take that and say, my honest answer is it is widely disseminated. A simple Google search will tell you everything if you just care to look. And it's at this point willful ignorance not to know a lot of these topics. And we are bringing it to you. We are putting it in front of you at Grand Rounds. It's in newspapers all over the place and journals. It's there for reading. You just gotta not close your eyes when it's presented. So I think it is widely disseminated at this point for anyone who is interested in seeing that. But you could have said something else. Maybe that was not going to be your answer. That was going to be my answer.
No. Oh, I was just going to give Joe a chance to talk again about, well, actually part of the challenge for what he is saying is that he's experienced a lot of racism in his field about disseminating his work. So I was going to give him that.
And who's controlling the levers of dissemination? Right.
Exactly.
But even so, I think it's out there. You just, yeah.
Yeah. And then the multiple sclerosis question was interesting. I think when, I don't know if that individual is still here, but whenever you're looking at,
he's still here.
Okay, let's see, where was that question?
About MS disparities.
Yeah, so, but what you were looking at in the MS disparities was the, where is that question? Oh, we were talking about amoebiasis. That's not it. Recent paper, Corey. Okay, when you're talking about disease progression of multiple sclerosis in certain race populations, I'd have to say that's probably going to be related to treatment, right? We see so many diseases. We're like, oh, golly, it's like breast cancer is more common in European Americans than Black Americans, but or African Americans, but mortality is so much higher in African Americans. Well, yeah, access to care, appropriate treatment, nutrition, stress, all of those things. And, as an autoimmune disease, multiple sclerosis is going to be responsive to stress. And I haven't read those data, but I think whenever we talk about, this is what I said, whenever you see a difference based on socially defined race, you have to ask why and recognize that it's not going to be, 99% of the time, it's not going to be genetic. It's extrinsic causes.
All right.
And just, yeah. All right. Thank you very much.
Okay.
Have a great
day.
day.
Bye. Have a good day, everybody.